Oh, Por favor.
Hello, John. Are you able to hear me?
Hi, Daniel. How you doing?
I'm okay. I think I'm getting to grips with it.
Yeah, oh yeah. Well, people tend to come late to this. Uh, Get my camera set up. You have quite a website, Daniel.
Oh,
I, I've
thank you.
I've told you that before, right?
Yeah, thanks very much. It's sort of the 21st century equivalent of patient information sheets, I think.
Yeah. Well, it catches the eye. It catches, yeah, and it's efficient. Uh, and
Well, I have a colleague who tries to learn something new every year, like a language. Uh,
Really?
yeah, I can't quite aspire to those sort of standards, but I decided one year I was going to try and teach myself to code a little bit and web design and so on. So most of the websites I've done over the years have been uh, myself, part
Oh, okay.
as a bit of a hobby in its own right, rather than commercial enterprises. So they can be a little bit shonky in places, but as time's gone by, it's got a bit slicker.
Well, you know, there are a lot of I haven't learned how to make them by AI, but you can make websites really easy. Now, I don't know how to do it. Daniel, I can meet Takashi Khan. He's a neurosurgeon from Japan. He's going to do the moderating. Hello, Takashi. Good morning.
Yeah, good morning. Good evening, Dr. Daniel Walsh and Dr. John. And I'm Dr. Takashi Kon from Tokyo, neurosurgeon Tokyo. So today
Hello.
I will introduce Dr. Daniel Walsh.
Thank you.
Okay. And there's
Okay.
Martin. Martin, I'd like you to meet Martin. He's a neurosurgeon from Dubai. Hi, Martin. Good morning. Did you get in, Martin? Hey, Martin. Good morning.
Hi there. Second time around this time. I
Yeah,
got a bit of a sunburn. It's quite hot down here.
yeah, I'd like to meet Daniel Walsh, neurosurgeon from London.
Right. I listened with great interest to his lecture yesterday. He gave it to the Pakistanis, and my senior registrar who was working with me, he's from that place, and so I do follow a little bit what they're doing.
Oh, thanks very much. Nice to meet you.
Yeah, nice to meet you too. I understand you're in King's College, which is quite a reputed place there in London, isn't it?
Well, we like to think so. Hopefully, I won't.
Right. Well, I mean the classical place is Queen Square, no, but I don't know. People people have changed their mind about it ever since well since a few decades, I guess.
We have a range of monarchs and minor
Right.
royals represented in our hospitals.
Right, right. Yeah, my mentors, were I was I'm Swiss, okay, and so I had the privilege, the luck or unluck, to be a resident during Professor Jasekil's time in Zurich. So I learned a lot of rat surgery, which has helped me over the years, and I also saw a lot of stuff, of course, but yeah, and then my other mentors were all British trained. I went to New Zealand and I was working there as a senior registrar in Auckland. Yeah.
Lovely. I've colleagues that I was in fellowship with in Auckland.
Were you?
Mm.
Oh,
And in Wellington. I did my own fellowship.
in Wellington,
Um,
right?
we met a lot of Kiwis while I was there.
Yes. Some of them I met them. There was a meeting in Sydney in 2001, just around the time when this attack on the New York Trade Center happened. And,
Yes. The notorious WFNS.
right. And I was there, and I was surprised to see some of the house surgeons. They recognized me because I was there in the early 90s, and so late 80s, early 90s, like that. And yeah, they became neurosurgeons, and they thought I have been a great role model. So that kind of gave me a little bit of a boost because, as you know, neurosurgery is sometimes not always well, you know, yeah, you're not always sure where you're going with it. Anyhow, yeah. Have you been in North America at all?
Not to train or work in neurosurgery. I've visited a few times and obviously gone to meetings and so forth.
I did a skull-based fellowship with Fred Gentili in Toronto. Yeah. And then suddenly I saw on one of these webinars, they're all saying Fred Gentili, and I found out through one of my colleagues that he actually had a glioma and he passed away.
Yeah, very sad.
Yeah.
Very highly thought of by all its friends.
Yeah.
John, can I ask you? I don't see any evidence of a camera.
Okay. I'm glad you brought that up. You presented yesterday, right? So
I did, yeah.
So there was a camera on your screen yesterday.
Yeah, it's just not present on the interface today.
You may have to reboot or update your Zoom, which is very easy. Let me just give you the address in the chat to update your Zoom. It's real quick. Okay, I believe that's the. You see the address in the chat?
Actually, no.
It's in the chat box of this webinar. Zoom.
No.
Okay, hold on. No, it's that's not it. I'm trying to get the address of Zoom. Oh, hold on. Hold on, Daniel. I'm getting it.
It's okay. I'm just trying to log into Zoom on a personal account as well. See, does that help?
Okay, updating Zoom to the latest version. Okay, I'm going to put it in the chat of the Zoom, okay? You see that link, Daniel, in the chat of the Zoom?
I do not.
You see that at the bottom, there's a chat option.
Oh yeah, I have the chat box open, but there's no
Okay,
hearing.
you don't see it?
No. I suspect the time-honored solution to this is to log on and log
Yeah,
off.
try that. That never hurts to reboot.
Okay.
So
Bear with me for a moment.
turn off completely your computer and come back in. There's no hurry.
Takashi, what time is it in Japan?
Now 9 p.m. It is 9 p.m.
9 p.m. Right.
Yes.
Are you actually in Osaka or in Tokyo?
Now in Tokyo.
You're in Tokyo. Okay.
Yes.
We had a conference once in Osaka, and that was
Osaka.
quite. Yeah, I liked it actually. I liked.
Thank you. Yeah,
Yeah,
this is my background is Mount Fuji, so between Tokyo and Osaka.
Yeah.
Osaka's conference when?
Oh, it was before COVID, maybe 2019, something like this.
2019. Okay.
Yeah.
Neurosurgery meeting. World.
Yeah.
Japan. Okay. Japan Neurosurgical meeting. JNS. 2019 will be in Osaka. Yes, I was there.
Yeah. Well, you weren't the only one. So,
Okay,
well,
but
we cannot. Yeah.
Go ahead.
I'm translator. I'm attending as a translator for foreign people, the Japanese into English.
Okay.
Oh, good. Oh, there's Nora. Nora, how you doing?
No. Pakistan.
You know, Takashi, I was, I know a little bit of Chinese actually. I can speak with people, but in the letters, I'm not very good.
Yeah,
I'm not very good, but
also for me.
Yeah, but I found out, like Kawa, as in Kawasaki, Kawa, is the same sign in Chinese, and it means river, like
yes,
like,
Kawa. Kawa is river. Yes.
Yeah, and it's the same sign. Just you say Kawa, and they say he or Zhang or something. So
Yeah.
so it's very interesting, how these totally different system, but there is a systematic behind it. And yeah, but you guys, you have a writing system that also includes some so many different elements to it. There's the Chinese traditional letters. There's the, what is it called? The other ones,
Chinese.
the Chinese letters, and the
Kanji.
Japanese, the kanji. Yeah.
Yeah, and Japanese letters, the hiragana and the katakana.
And then yes. So I think this is really quite stimulating for the brain to know all these different things, no?
Yes, three types of letters we use in Japanese.
Yeah.
And grammatically is very complicated, I think.
But the language itself is beautiful. It sounds like Italian to me. It is very clear in the pronunciation,
Pronunciation bit. Thanks.
Yeah,
thanks.
very clear pronunciation, not like English.
Yes.
Not like English.
Not like English, not right.
No.
That's why Japanese, not all Japanese can speak English, because English education is, there is also some English education, but they are not emphasized on conversation. Reading books or some reading or grammar.
So I think in an earlier webinar, you told us that you would like to travel around the world and meet all
Yes. Neurosurgical travel is my dream, and flying all over the world and meet the acquaintances and learn and teach English and neurosurgery. Yes, neurosurgical trips is my dream.
That's our future.
That future. So
that's right, Takashi. We'll travel the world, go to various programs.
Yes, various programs.
Put on webinars.
Yes. That's my dream. With
John Bennett. That'll be fun.
Yeah, that'll be fun.
Well, you're most welcome. I'll put my email address in the chat box.
Okay.
Right now. So if you need to contact me.
Okay, thank you.
I'll put it there right now.
Okay, thank you.
Nora, are you available? I don't know if you're available to talk.
Hi, yes.
Hi, Nora. How are you doing?
I'm doing great. Yes, I'm doing great. How are you? So good to see you.
Yeah, we have a few people. Takashi, right?
Yeah.
Yeah, and
I know.
Martin from Dubai.
Yes, I know.
This is Nora. She put on the conference.
Hi, Nora.
Martin is Dubai.
Yes.
Yes, yes, I know.
Here comes Daniel now. You recognize him.
Daniel. Okay.
Noah ran the Pakistan webcast yesterday.
Yes,
Pakistan,
Dr.
yes.
Yes, Dr. Martin Buteri, I have seen you as among the attendees several times, so it's so good to see you here as well. It's an honor to have known you, and I think that you are one of the editors of the Park JNS.
Okay,
Am I right?
Yes.
excuse me, Noah. Daniel,
Yes,
Daniel,
I
you
am one
back
of the
in?
editors. It's true.
Daniel, you back in? Hold on, folks, with Daniel.
And Noor, you know, I
Okay,
have.
there you go. There, Daniel's here.
Okay.
Hi,
We
sir.
can talk later, Noor. Okay, bye.
Sure,
Okay,
sure. We'll
Okay.
do.
ready to start, Daniel?
I am, yes.
Okay, 10,
Okay.
9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from sunny Miami Beach. We have the honor of having the bi-monthly Chinese Neurosurgical Journal webcast, and we're featuring Daniel Walsh this week, and we'll let Takashi Kan, a neurosurgeon from Japan, introduce Daniel. Good morning, Takashi.
Okay, thank you. Thank you, John. So it's a great pleasure, great honor for me to introduce Dr. Daniel Walsh to introduce. He's a neurosurgeon from King's College London, England, and also he's associate editor of the British Neurosurgery Journal. Today, he'll give a speech about microsurgical treatment of intrinsic arteriovenous shunt. Dr. Daniel Walsh, please.
Thank you very much for that kind introduction. I'm just going to hopefully share my screen with you now. And if
it works,
you could just let me know that you can see what I hope you see.
Yeah, perfect.
Wonderful.
Okay.
Thank you very, very much. It's a great honor to be invited. And I'm going, hopefully going to be able to welcome some of the observers who are in our unit at the moment from China. In the group, I can't see at the moment, but we have a number of observers with us from China. We have regular visitors from there, so it's really great to connect, as well as with everyone else from around the world who participates in neurosurgical TV. I'm going to talk a little bit about intrinsic spinal cord arteriovenous shunts, which is, as I said last night, you mentioned I've been boring people with this topic all weekend. But this is a subject very dear to my heart. We all meet diseases that we seem to encounter a little bit more frequently than the average. We get our own little niche, and this has been one of mine. And it's proved a very rewarding area to participate in. And I think has seen some exciting evolution in the surgical sphere over time. I'm not today going to talk about the more common dural arteriovenous shunts that make up most of the workload, but I'm instead going to focus on the rather enigmatic group of shunts that affect the spinal cord itself. The spinal cord essentially can be thought of being irrigated by two circulations. There's an extrinsic element, which, as well as irrigating the dura and draining to the epidural veins, provides indirect blood supply to the cord. But the vessels which themselves make up the intrinsic circulation of the cord consist of an anterior longitudinal axis, the anterior arterial axis, and two posterior axes, which descend along the length of the cord and give segmental supply following the roots emerging as they do so. So the diseases I'm talking about today are uniquely irrigated by just elements of that arterial circulation and then drained into the venous system surrounding the cord, which itself communicates in a somewhat complex way with the epidural veins and indeed the extraspinal venous system. There are even transmedullary veins that have been identified in animal models over the years. So I won't spend too much time therefore on classification, because the only elements of the commonly used classifications that we're talking about are either the type 2 arteriovenous malformations of the cord or perimedullary fistulas, where the arteriovenous shunt is occurring on the peel surface of the cord itself. A word about investigation. The criterion standard very much remains catheter angiography for intrinsic spinal AVMs. Yesterday, I talked a lot about how we had a desire to reduce the amount of radiation and contrast load, and indeed the duration of spinal angiography that's often necessary to do a full interrogation of 54 pairs of segmental vessels and the intracranial circulation, which is what you must do to do a complete angiogram. However, when it comes to intrinsic lesions, cross-sectional dynamic vascular imaging has really not been able to match the level of detail that one sees with catheter angiography. And we have actually found that with polyfistulous lesions, dynamic MRA, which is so reliable with dural shunts, simply doesn't provide us with any useful information most of the time, at least in our experience. It doesn't tend to send us on wild goose chases or reassure us falsely. It simply doesn't show the architecture of these polyfistulous lesions. And when we published our experience with dynamic MRA some years back, we noted that while it could be very sensitive to the presence of a dural arteriovenous fistula and reasonably specific as to level, when it came to polyfistulous lesions of various architectures, we were always unable to resolve that architecture. So the message there is that catheter angiography remains absolutely what is needed if you have a clinical suspicion that there might be an intrinsic arteriovenous shunt. CT angiography has something of a place in the investigation of these lesions, particularly for providing topographic information about vascular structures on the cord or adjacent to the cord. But perhaps even more useful when it comes to intrinsic lesions is this technique of 2D flat panel tomography, essentially allowing one to generate very nice detailed CT scans during angiography. You can see it being done there with a brain AVM just for demonstration purposes. But on the right, there's a perimedullary fistula, which we can resolve the arterial and venous elements of, and then just take apart slice by slice to understand the architecture in detail. And I'm hopefully going to show you examples of how useful that can be. If you're not very interested in this subject, the default, the assumption that tends to be made is that really the only effective treatment for these lesions is endovascular treatment, and also the only reasonably safe treatment. That has, there's no doubt that transarterial embolization has become a very valuable tool for the treatment of these lesions, but it's any of our interventional neuroradiologists will tell you it's often still a fraught and technically difficult procedure to accomplish safely, and one has to exercise a lot of good judgment to avoid inadvertent exclusion of normal elements of the circulation in the cord. But a variety of tools are available, including glues and liquid embolic agents, even sometimes coils with giant macrofistulas. And that is, in our department as well, our first line therapy for intrinsic arteriovenous shunts. But that isn't to say that these cannot sometimes be reasonable microsurgical targets as well. Transvenous embolization in the spine is an exciting and evolving area with a lot of experience being accrued navigating the relatively complex venous drainage of the cord, particularly with regard to the treatment of CSF venous fistulas at the moment. And I've no doubt that will translate into an increased experience with transvenous embolization of arteriovenous shunts as well. Stereotactic radiosurgery, certainly in our practice, remains to find its place. The targeting of small lesions in the cord, which is itself very mobile with respiration, is a challenge in its own right. And of course, there's a degree of worry about cord toxicity that has to be managed. There are some institutional series showing reasonably effective outcomes with tools like Gamma Knife or Linux-based radiosurgery. Although it really remains to be established precisely where the most robust indication for it is in this sphere, I think. While all of these exciting technologies have been evolving, surgery hasn't been standing still either. And I want to make the case to you that certainly even over my career, the approach one is taking to an intramedullary AVM, for example, has shifted from thinking of it as a vascular mass within the cord that requires removal to being much more selective in targeting elements of the pathophysiology with control from intraoperative neurophysiological monitoring, real-time vascular imaging that can be provided not only by ICG, but increasingly by intraoperative spinal angiography that can be, that's available more now as more hybrid operating facilities become available. And for the placement of a catheter for spinal angiography can be accomplished through, for example, the popliteal artery, making it a little bit more practical in that setting. It's not something we've managed to do yet, but I'm sure in the future it's going to come. We have new tools to help us see better in small spaces, and I'm going to hopefully show those to you. And this has all led to a reevaluation of what the microsurgical strategy actually is in treating such a shunt. Because I think we've lost sight of the fact that one of the most powerful tools the surgeon has in this setting is point disconnection. If you can identify a transition point between artery and vein in these pathologies, and very precisely divide it with little injury to the tissue around it, and without the risk of either refluxing material proximally or going too distally to occlude normal circulation, that is probably the most desirable way to arrest flow. I borrowed a lovely illustration here from Flores et al.'s publication on the various subtypes of spinal AV shunt, just to illustrate the first intrinsic shunt I'm going to talk about, the perimedullary fistulas. These were recognized in the late 70s and early 80s as a distinct entity from spinal dural AVFs. The Peel AV shunt occurs usually involving the anterior spinal artery, and but it can involve the posterior axis as well. They may be single fistulas, as in the illustrated example, and the cross-sectional imaging appearances of those will be very reminiscent of a spinal dural arteriovenous shunt. So the angiogram is absolutely key in making the diagnosis. When they become polyfistulas, or they can even be giant with large venous varices, they come to resemble arteriovenous malformations. And again, sometimes there's a little bit of confusion in distinguishing the two. But with a perimedullary fistula, the point of fistulation is on the Peel surface. And if one can identify that point, the transition from artery to vein, and it can be accessed either endovascularly or surgically, there is an opportunity to cure the lesion. So if we take an example of one that's really quite straightforward, this patient is presented with a rapidly progressive conus syndrome. You can see the characteristic appearances of a vascular malformation here. These will sometimes be reproduced by an epidural or a dural AVF as well, where you've got very busy vascular flow voids on the dorsum as well as ventrally on the cord. It's perhaps a little bit more dense than the typical spinal dural AVF here, but the appearances vary enormously, and that might be a clue to what's going on. And in actual fact, this is an example of a perimedullary fistula which is being fed by the posterior spinal axis. It proved a little bit difficult to access transarterially, but surgically it was relatively straightforward. With the fistula's point just underneath the venous complex here, and it's a relatively straightforward matter to divide that. The veins collapse, and the patient is then able to mount something of a recovery. We've even encountered them in situations where we we're unable to unravel the architecture of the shunt on because of, for example, very severe aortoiliac disease that made angiography technically difficult or impossible, in fact. Now, I have encountered patients over the years who, when they've run into this situation, the conclusion has often been that this might therefore not be an AVM. And there are other potential explanations that can be advanced, like neuroinflammatory disease, for example. But I think if you've raised the question of an arteriovenous shunt, it is often very, very important to try and pursue it very aggressively, because there is a big risk in time going by and interventions such as steroid therapy being associated with neurological deterioration. So in a situation like this, where we have flow voids in and around the cord, we have the central high signal within the conus that is indicative of a ischemic radiculomyelopathy. There are occasions where we have, if the cross-sectional imaging gives us enough to give us a starting point, we will explore. And this is that same case where we've done a laminectomy at the busiest vascular level. And as you can see, there is clearly a vascular pathology visible on the dorsum of the cord. Again, very similar to the first one I showed you, a fistulous point down here, which can then be divided and cured. There's the ICG of the same procedure. And as you can see, the native posterior spinal axes persist afterwards, but the veins collapse utterly. There are, though, still situations where we all struggle to access these fistulous points. And just to illustrate that, here's a case of a gentleman who came from another institution with a slowly progressive thoracic myelopathy, very slowly progressive, but it was gradually being disabling, and one would like to offer treatment. He'd had an attempt at endovascular treatment elsewhere before he came to us, and we attempted it again because the lesion is a perimedullary fistula, which the point of fistulation is just, if you see that sort of omega loop that then continues on as a venous complex that goes down the opposite side along with the nerve root. That's the point at which needs to be reached. And unfortunately, it was just not possible to maintain a stable microcatheter position for long enough after multiple attempts to try and safely embolize the lesion. Surgical address of this would have, well, in our view initially, would have required a direct ventrolateral approach, transthoracic, maybe with a vertebrectomy at more than one level, and the complex reconstruction that goes along with that, in order to be able to get enough access to move around these veins and see this fistulous point reasonably safely. And while it's probably feasible with the assistance of my complex spine colleagues, none of us felt it was particularly advisable, and it was not palatable to the patient. So ultimately, they opted to have radiosurgery to the lesion, was followed for 5 years, but unfortunately, that really didn't have much effect on the arteriovenous shunt, at which point they came back for reconsideration. And with the way our tools had evolved in the intervening almost decade at that stage, we reconsidered the possibility of operating on this from a less invasive approach. So as I said, the fistulous point one would wish to reach on angiography was about here. If we divided there, then the native veins that fill nearby would be preserved, and the arteriovenous shunt should be abolished. And the tomography studies allow one to identify that and relate it to the bony anatomy as well as the cord anatomy a little bit better. With that in mind, this is how we approach the lesion from a posterolateral approach and a pediculotomy, drilled down to allow exposure of the nerve root and division of the dentate ligament to rotate the cord a little bit. This is the venous complex exiting along with the nerve root that one first encounters. But of course, if we just diathermy that, we're going to leave persistent AV shunting ventrally and probably not accomplish anything at all while exposing the patient to the risks of the procedure. So how can we get more ventral in this very tight spot, what we use is the 45-degree endoscope, which when introduced here, you can see on the right side, that is the view. And I'm hoping to persuade you two can see, appreciate on the front of the cord, that omega loop I was talking about. We were able to see the venous outflow near us in the foreground, and we could be confident that dividing this with an angled diathermy and the aid of a microwave EM clip allowed us to transect that fistulous point, which abolished the arteriovenous shunt completely. So that showed it was technically feasible to do this, although one would have rather undertaken this many years before. But it shows really how the surgical technology that we have has evolved enough, and the confidence we've developed in using it has come along to make things we once thought were not operable much more feasible. A topic I often bring up when I give these talks is the subject of patients presenting with cisternal subarachnoid hemorrhage. And this is an example of one. This is a young lady who was jogging on the treadmill one day when, if you took a very careful history, she got a sudden interscapular pain, which very rapidly became an occipitocervical headache. And as she presented to the emergency room, that became the narrative. She presented with occipitocervical headache, characteristic of subarachnoid hemorrhage. She was vomiting, very worst headache of her life. And she had a CT scan which showed subarachnoid hemorrhage. She was investigated thoroughly, and in our practice, we routinely arrange neuraxis imaging, usually about 6 weeks after the index presentation, if we've not identified any intracranial abnormality on 2 sets of vascular imaging. And that is what occurred in her case and resulted in the diagnosis of this arteriovenous shunt, which is lying down in front of the conus, in actual fact, with a vein, presumably a venous aneurysm, we think, presumably the source of the index hemorrhage, rupturing and shooting ventrally to result in her presentation. So the endovascular treatment of this was precluded by difficulty getting distal enough access along a relatively tortuous anterior spinal artery, while preserving en passant supply to the conus basket nearby. So this was a case we took for surgery, and in fact what we encountered at surgery really confirmed that suspicion. This was the source of the original bleeding. Very tense venous complex, which as soon as we start to manipulate, immediately started bleeding as well. Sufficient that we really couldn't manipulate it enough to get rostrally in front of the conus to identify the fistula's point. Until we had sequentially collapsed all of these veins. We start at the bottom, collapse these veins down, completely distinct from the dogma that arteriovenous malformations, you take the arteries first and collapse the vein. With an arteriovenous fistula, the disease is of the veins. So the veins need to be closed, and you can work backwards along the venous complex until we eventually reach the transition point here, and we're able to close it. So subarachnoid hemorrhage can result from spinal vascular malformations, however rarely, and the consequences of missing that diagnosis can be, or at least so serious for the patient, one wouldn't want to deny them something as relatively harmless as an MRI scan. So if we leave the fistulas and move to arteriovenous malformations, these are the homologs of the brain arteriovenous malformations that we encounter. And like those, they can be either compact or glomous, as in this illustration from the same publication, or fistulas, sometimes called diffuse. And I'll show you some examples of those. When you have a compact arteriovenous malformation like this one, and this is one that had recently hemorrhaged and was quite aggressive. I think it had hemorrhaged 2 times at the time we came to surgery. there is no choice but to make a myelotomy in the cord, in this case a dorsal myelotomy, to expose the nidus and extirpate it from the cord in just the same way one might remove a arteriovenous malformation in the brain. Very often, though, this might not be the only surgical strategy available to one. When one encounters a lesion like this, then you can be reasonably confident it's going to be a good strategy, because the peel representation of the arteriovenous malformation in this case is on the conus, and Professor Spetzler would identify this type of AVM as being uniquely suited to surgical extirpation. As you can see, it continues on down into the lumbosacral canal and between the elements of the cauda equina. This was a young man who had presented with a very rapidly progressive conus syndrome that left him virtually paraplegic within 2 weeks. Not as a result of hemorrhage, but as a result of thrombosis in the distal element of the AVM. So there was a back pressure, one presumes, and congestive myelopathy. And after the AVM was completely treated, a degree, the environment was right to allow for at least a degree of recovery, and ultimately he became ambulant again, although he lives with the scars of this event to this day. But has had some significant neurological recovery, and it never recurred. I think this was a good 10 years ago at this stage. This is another example of one of these conus arteriovenous malformations. The imaging appearances can make it a little bit difficult to decide if you're dealing with a perimedullary fistula, where really we just need to interrupt on the peel surface, or to completely exclude the lesion, we've got to extirpate the nidus. And if we are entertaining extirpating a nidus, as is the case here, we would like to know where exactly the peel representation is. So the first example I gave you was very obvious. It's a very large lesion. You can't miss it. This, though, sitting at the conus, your surgical approach really would be best determined by knowing where the elements of the AVM are situated. And here is where tomography, again, can be helpful to us. You'll see on the cross-sectional imaging that the MRI doesn't tell us a great deal about where's the conus, where's the element, where's the nerves coming off, where's the AVM. It's very difficult to distinguish. But with the tomography, we can clearly make out that the peel representation of the nidus in this case is ventrolateral, and that allows one to say, well, the optimal approach to this area is similar to if one was operating on a thoracic disc, would be a ventrolateral approach. In this case, we chose a costotransversectomy and a particulectomy, and that then allows us to section the dentate ligament again, gently rotate the conus, and now you see with the ICG demonstrating that same angioarchitecture, we have good access to the whole of the malformation and are in a position to completely extirpate it with as little trauma to the adjacent cord as is possible. And again, that we were able to completely remove that AVM. However, when they're not compact and they're not presenting to the peel surface, we have another problem. This is a young lady who presented with 2 episodes of microhemorrhage at C1, both of which presented as transient dense quadriparesis. They were quite terrifying for her, although happily she made good neurological recoveries on each occasion, although was left with significant neuropathic pain. And the cause of all of this is a fistulous AVM within the cord, irrigated by that afferent branch coming off the vertebral artery. There's a little diffuse nidus in here, and then it drains caudally to the coronal venous plexus. Our MRI doesn't, again, tell us a great deal about the location of that diffuse nidus within the cord, or its relationship to those vascular afferents and draining veins. So again, the topography can be helped a lot with tomography. And when we study the tomogram, we're actually able to resolve precisely where the arterial inflow is going into the diffuse nidus, and where the draining vein is forming and descending caudally. And that enables us to consider a surgical approach to this. Although it's an anterior in, very high in the cervical cord, we can access this area through a far lateral exposure. What we don't need to do, because we have access to all the irrigating and draining vessels on the peeled surface, we don't need to go into the cord and extirpate this nidus. And this is the in situ disconnection technique, which was, at least I learned about from the work of Professor Robert Spetzler. I think initially he was interested in it as a means to treat cord AVMs as well. And it has become a real mainstay of our surgical strategy with these lesions. And let me just show you how it works. You can see there through the exposure, we're able to identify the single vertebral artery going in. The diffuse nidus is in here. We don't need to trouble with that, but we do need to identify where the draining vein coming off below is. And then with a pair of microclips and low power bipolar, one can simply isolate that nidus completely. And that afforded a really, really gratifying recovery. There were no further episodes of hemorrhage. And uniquely in my experience, because this really doesn't happen, even her neuropathic pain seemed to get a little bit better over time. So really, really useful once one can unravel and understand the architecture of the shunt. Here is yet another example of a patient who presented to the hospital with a cisternal subarachnoid hemorrhage, and subsequent investigation eventually showed that this was the result of a anterior spinal artery aneurysm associated with a diffuse nidus at about C1 as well. And this is another situation, therefore, where we don't have very good transarterial access to the lesion. There's concerns about, either reflux or excessive penetration of the area, resulting in local vessel occlusion that would be undesirable. So this was another case considered for surgery, and you see it through a similar exposure to the last case, far lateral. The vascular busyness on the cord here reflects the diffuse nidus therein. In the background, the aneurysm is adherent, stuck to the anterior thecal sac. You see it there. The ICG study illustrates that architecture, I think, a little bit better. We can see the afferents going in to begin filling the fistulous element of the AVM. You don't see the aneurysm fill, but you do see the draining vein, which we know from the angiogram that comes out pretty well directly from the aneurysm. So I would be cautious about concluding that the aneurysm has since thrombosed with ICG until we've actually opened it. And of course, we don't want to do that without controlling the inflow here. There could be a little bit of thrombus in the wall of the aneurysm, but it might still be viable. So we trap the AVM first, get some microclips on there. We have neurophysiology in place to monitor for any deteriorations in the anterior tracts, and we see the vein disappear. And when we see the vein disappear, we now know it's going to be safe to pop a needle and diathermy that aneurysm, which is what we do. Divide these vessels, and that's it. You don't incise the cord. And that patient again woke up with no new neurological deficit and a control angiogram showing complete occlusion of the shunt. And he remains well to this day. This is again a young woman, neurologically perfectly intact, very healthy, and then suddenly develops a severe occipitocervical headache. And she was admitted to another institution with where they very, very promptly identified that there had been a vent in the cord. You can see a little hematoma here within the cord. The clue, apart from her history, which in most ways was indicative of a subarachnoid hemorrhage, however, her left upper extremity was nearly completely paralyzed, which was unusual. So that gave the clue that the problem was here in the subaxial spine. and a CT angiogram done early on gave a clue that there's a lesion there. The MRI doesn't help resolve the architecture of the lesion a great deal. There's a suggestion that there may be something indenting the cord here, which is vascular in origin, but the cord itself there's a lot of blood products and a lot of swelling in the cord at this stage. So very wisely, they elected to wait a little while, and indeed she did recover neurologically. They carried out a catheter angiogram, which confirmed that there was an AV shunt present. And that AV shunt is, we would probably classify it as a reasonably compact but intramedullary AVM, irrigated through branches from the ascending cervical trunk and draining into a venous complex, one of which goes down the ipsilateral side to the arterial inflow along the radicals, but also to the other side, again, following the nerve roots down. So this was listed for endovascular embolization, but unfortunately it was not possible to proceed safely as again, it wasn't felt the microcatheter could be put in a reasonably safe position to deposit the material, and an opinion was sought on surgical treatment. And the surgical plan really all rests again on studying the angiogram in the light of the tomography available. We know that there is a hematoma cavity by the time we see her, which is getting a little bit smaller. We can see the vascular structures within the cord and follow the radical out down the side. And on that basis, we plan an operation to in situ deconstruct that malformation. As we go along, we're using a contact electrode there to monitor D waves during it, and there's the ICG showing the nidus. So little by little, using those microclips, we just start taking down the afferents that we're reasonably confident from the angiogram fill the AVM, and monitoring as we go along with repeated ICG to document gradual devascularization of the shunt. And where we've demonstrated as far as we can that it is safe to transect arteries going into the area, we do so low power amplitude, bipolar, and sequentially we see the amount of flow reducing to the point where really it becomes a monofistulous lesion, with that afferent you see above draining down the veins on this side. And the ICG eventually reassures us that we have, as far as we can tell, interrupted the complete shunt. What's really striking about this technique compared to, say, an effort to make a myelotomy here and resect the whole nidus. So there's a husk of nidus that exists within this cord that I'm inviting you to believe is no longer viable. But the real difference you see at the bedside is how well the patients tolerate that approach compared to making a myelotomy. And this young lady was out of bed the next day. Her parents, who are doctors themselves, said that they couldn't actually believe she'd had the procedure, had she had a sham procedure. You know, they meant jokingly. And that's not necessarily, I think that reflects the approach. If one can avoid intruding into the cord too much, it can really, really help with recovery. So 3 months on, her neurology was at its baseline. She's going to have a degree of intrinsic hand weakness, I think, in the long term. But her angiogram is clear, MRI looks stable, and the reason I show it here is just to show the husk of the malformation that the angiogram reassures us is dead. However, all of these patients I do carry out long-term angiographic follow-up on. To date, I've not been disappointed, but one is always one case away from a failure. So I think it's beholden on us to follow these folks up carefully. Is another problem to contend with. Again, it's a young person who suddenly develops a Brown-Séquard syndrome very severe interscapular pain. The MRI here showing blood products and a lot of swelling in the cord. And he's quite disabled at this point with Asia D deficit. The interesting thing about this case is an early CT angiogram showed a round lesion. It's very suspicious in the spinal canal. And that immediately, as well as the history, of course, and then the MRI findings, is there a vascular shunt here? So an angiogram was arranged reasonably soon. And in actual fact, the angiogram didn't show any aneurysm concordant with that finding. You're looking at the AP views here. There is evidence of a sort of fistulous AV shunt, sure. You can see a vessel descending down there and some airly filling veins in this region, but nothing more than that, and certainly no aneurysm. So we decided to wait and allow him to recover. And then the really important thing to do is to look again once the swelling has gone down. And what do we find? A few weeks later, there is the aneurysm, loud and proud, filling. And of course, that's quite an alarming finding in somebody who's recovering neurologically from a nasty cord injury. I don't think any of us would consider that a stable or safe situation. And our team didn't feel this was necessarily a good a case to be preferred for endovascular treatment. We wanted to look at possibly in situ disconnection. And this case actually reflects to a certain degree a mistake, because I, was reasonably hopeful that we would be able to see some representation of that aneurysm on the anterior cord. Let me show you the intraoperative findings. So there we are, sectioning the dentate nearby. We rotate the cord gently, and then we introduce our 45-degree endoscope. And you can see the arterialized veins on the front of the cord. And we spent a lot of time looking, but I cannot see any real evidence of aneurysm. And I am not going to make an incision in the cord in that location, because however thin and tenuous those, that neurological tissue is, it's going to potentially be viable. So the ultrasound is helpful in showing that we're in the right place. There is an aneurysm in there. And the best thing to do, I judge, in this case, is to make a myelotomy, which is in the dorsal root entry zone. And there we identify the aneurysm, which is in series with the arteries and the vein. So what we do is try and isolate that, collapse the aneurysm down with low power diathermy once again, nice and slowly under neurophysiological monitoring. And as soon as we can, get a micro clip onto the proximal vessel just to make it a little bit easier to see. And then once we've taken out the arterial inflow, we can go back and start closing the venous outflow, which is visible on the anterior surface of the cord running down the radicle again. And they're going back just to make absolutely sure that diathermy is gone. We take the clip off, and this is the control angiography, which happily shows resolution of the AV shunt. And this man is then able to get back to his neurorehabilitation and hopefully more recovery in the future. That's the control MRI at about 3 months post-procedurally as well. Just we always do control cross-sectional imaging as well to look for the development of things like syrinxes or arachnoiditis that might be are capable of producing neurological problems or exacerbating the neurological problem as delayed complications in these cases. So that was where I was going to leave it, hopefully having persuaded any of you who were skeptical that there is a very important place for microsurgical treatment of these intrinsic arteriovenous shunts. And as I said, all credit to the originators of the technique, but I think the in situ disconnection strategy is a very, very useful one that can make this considerably safer than it would otherwise be. But of course, we always have to be in a position to convert to a more conventional extirpation if necessary. And with that, I'll close by inviting everybody to, on behalf of the ENS vascular section, invite everybody to the Congress in Sofia, which will be held towards the end of this year. And I would love the opportunity to meet some of you there. And if there are any questions, I'll be happy to take them.
Thank you. Thank you, Dr. Daniel Walsh, for wonderful lecture. So it's very informative and really a lot of things to learn. Are there any questions or comments from the panelists, from the audience? Please raise hands. Any questions from the floor and the audience?
I'm sure Martin has. Martin, are you there? Perhaps he stepped away.
Hi, John.
Oh, there we go, Harshad. How are you doing today?
I'm doing very well, very well.
Welcome.
Well, hello, Professor.
Hello.
Hello, thanks, lecture. Very happy to hear you. And as always, I have heard you yesterday also, and wonderfully explained about the AV fistula and AVM. I would like to understand one thing. You've got a large experience of AV fistula and AVM, what I can say in the spinal region. What is the outcome following whether endovascular treatment or a surgical treatment? I mean neurological recovery. A patient presenting with a lot of neurological deficit, and how much is the recovery you have noticed in this kind of cases? In my experience, the recovery is always not full, but partial. What is your experience? What is your take?
Yeah, I think that's correct. And I think that the most important determinant of outcome is the severity of the neurological deficit you start with. So it's a little bit like intramedullary tumors. We're probably least confident and comfortable operating on people who have recovered very well or have little in the way of a neurological deficit, yet they have probably got the most to gain from an aggressive approach to certainly a symptomatic AV shunt. And I think irrespective of whether you're treating them endovascularly or surgically, it's where you're starting from is hugely important. It might well, as you saw, there are many cases there where we deferred intervention for a period of weeks or in some cases months. And patients will often, after an initial quite dense insult, will mount a significant, albeit partial.
Subdurate. Yeah, and we remove the clots and we find this kind of fistula or an AVM, and we try to, I believe that we have to do only the arterial inflow to be blocked. And the recovery we have seen is very, very slow, insidious, and may not be 100%. So this is something which we have to understand. And if we can diagnose very early, basically the problem is a venous hypertension, and they cause the problem. And if we do before the neurological deficit is set in, probably we may be able to cure these patients very well in terms of neurological recovery. This is my experience in whatever, I have a very handful number of cases of fistula. It seems you have got a vast number. And many times, very difficult to cannulate these arteries through the spinal angiography. And you can't reach embolize, and you have to resort to a surgical treatment. And yes, it does give rise to a lot of problems. The vascular insult is more than anything else, the compressive.
I think the importance of distinguishing fistulas from malformations is to recognize that the arteriovenous fistulas are themselves usually a disease of the vein. And when we talk about, transecting the arteriovenous transition point, the more important element of that is the venous drainage, I think. And I think if you can close the venous drainage in a fistula, you will more often than not fix the problem, because the arterial ingress will roll back. With the malformation, in order to be confident that it's not going to recruit back, we have to be able to completely exclude both inflow and outflow.
Okay.
Right.
Thank you.
Right.
Thank you. And
Thank you.
I would like to ask, Thank you. I would like to ask one question, Dr. Daniel Walsh. So, it's a spinal congestion is very difficult to diagnose earlier. So sometimes, medically or conservatively managed by not following MR image, and medically treatment or sometimes neuropathy, only to diagnose the neuropathy, and very difficult to distinguish between efficient small vessel malformations. In that case, we usually do MR image or 3D CT scan. Sometimes cannot lead to angiography because so less understanding of medical management and less understand about underdiagnosed. In that case, the way to diagnose earlier. So, do you have any idea of educating physicians for this disease to find this disease or symptoms?
Yeah, well, I think being familiar with the differential diagnosis is absolutely key.
Mm.
The healthcare structure I work in is reasonably regimented so that patients with these type of disabilities tend to come through centers where there are multidisciplinary teams of neurologists and neurosurgeons who are quite used to working together. Um, and once you only need to see one of these cases in your lifetime, and you will think of it again if the same situation arises. But you're completely right. The median time to presentation in my series of ischemic radiculomyelopathy overall is 18 months. And that's 18 months of patients who have been doubly incontinent, unable to walk, having investigations like serum aquaporin levels, and sometimes having trials of treatment like steroid therapies. And I think this is reproduced around the world until they encounter somebody who says, have we considered the possibility of? And that very often leads to delays in diagnosis that I think do have a real impact on the longer term recovery, because you can sometimes see some really gratifying recoveries as well from congestive myelopathy if you treat it quickly.
Yes. Thank you. Yeah, thank you. Thank you very
And
much.
I should
very
add,
informative.
I should add the slightly unusual. We have a slightly unusual practice, and we have several times over the years surgically explored people where we had a high index of suspicion, and our neurologists were saying, "Look, this just doesn't fit completely with neuroinflammatory disease." So rather than giving empirical treatment for that, we've offered patients exploration, and you would be surprised at the number of times, like the case I showed, we have found neurovascular pathology.
Very good.
Thank you. Thank you. Okay, so any questions? Other questions?
I just
Okay,
have a
so
comment.
we'll
I just have a
conclude this.
comment,
Okay,
Takashi.
okay, can you comment?
Yeah, Daniel, you're traveling to
Yeah.
China, right? Did you mention
Yeah,
you're
in July.
traveling to? Well, just let us know if you want to have a webcast over there. I'll give you the option. Say, hey, John, let's have a webcast. I have something interesting I want to talk about in China, whatever. Anyways, thank you for coming out today. Thank you for taking the time. You took time yesterday. You're a busy
Thank you.
guy to give selfishly for education in neurosurgery. And I think we had the second speaker had an emergency, so unfortunately we won't be able to do that. So we're going to close. So thanks everybody for coming.
Yes,
And
okay.
one thing before we close,
Thank you.
Nora, are you there? Nora, are you there?
Yes, hi, I'm here. Thank you very much, sir, for the amazing lecture today as well.
Okay, Nora, I'm showing the webcast that you have coming up. You want to talk about it a little bit?
Yeah, sure. I'd love to tell them more about it. I'm so pleased to invite Professor Pascal Jabbour next month on June 7th. And this, like you all know, that Professor Pascal Jabbour has been considered as a pioneer of robotic neuroendovascular procedures. And I think that I was so honored to have him accept this invitation to deliver his lecture on innovations in the treatment of neurovascular diseases. So stay tuned, and I will be sharing more stuff about robotics and AI use in neurointervention and how it can revolutionize the treatment of stroke. And as you might have read about it, the Jefferson is the first center who has been using a lot of robotics and AI assistance in the treatment of neurovascular diseases. So I've also mentioned in my own groups that I know that some of the concepts that I've been discussing during our news webinar series are a little new and a little unique, and sometimes I totally understand that in many centers in some part of the world are not using some type of innovative concepts. So I believe that thanks to all these wonderful teachers, we are bridging the knowledge gap between the developed and the developing and the underdeveloping, developing and the underdeveloped centers. So I will be sharing more stuff on robotics and AI in my all of my WhatsApp channels, so that the attendees who wish to listen to it and have a good insight and be interactive during the session can prepare themselves for this wonderful session. I'm so excited about it. So thank you very, very much. And again, I want to tell that News is a free and accessible channel that has been founded by me, and I'm so happy to be running it. And it is global. It is accessible for everyone in the world, and even the aliens if they wish to join the Zoom link. So it is totally accessible globally for everyone, and I have got special interest in the low middle income countries. And
very good, Noor. It's
Yes.
good to have you here. It's good to have you adding to the education. You're a real asset to the neurosurgery community. And okay, we'll close the proceedings then. Thank you very much, and we'll see you in 2 weeks. Daniel, thanks a lot.
Very welcome. Take care. Nice to meet everyone.
Okay.
Thank you.
Yeah.
Stick around.
Bye, Daniel.
I'm just going off the air. No, I'm gonna stay here.